declare it a quorum, even though there may be some more who drift in. I'm Carol Runyon. I'm director of the PIPER program, the Program for Injury Prevention, Education, and Research. And this seminar is co-sponsored by the Kemp Center for the Prevention and Treatment of Child Abuse and Neglect. Before I introduce today's speaker, though, I want to remind you that, or not remind you, but tell you that our next seminar will be December 15th at noon. And the speaker will be Sabrina Matson from UC Boulder, talking about work on school violence. We don't have the exact title yet or the room, but stay tuned and we will be sending that out before long. So today I'm pleased to introduce a longtime friend, colleague, former student, Shankar Viswanathan. How did I do?
Perfect.
I've been practicing how to pronounce his last name for about 15 years now. Shankar is assistant professor in the Division of Biostatistics and Department of Epidemiology and Public Health at Einstein Medical College in New York City. Before that, he was at Chapel Hill as a doctoral student in biostatistics, finished his degree in 2011, and moving back. Before that, he got his master's at Christian Medical College in India in 1996 and worked there for about 7 years before coming to the U.S. And so while in graduate school, he worked on a number of projects through the Injury Control Research Center at Chapel Hill and has continued to work in the injury area on a variety of topics. Today's topic is on the history of child maltreatment and its impact on psychosocial and high-risk sexual behaviors in inner-city minority adolescent women. That's a mouthful. So welcome, Shankar.
Thank you, Carol.
And he says it's all right to ask questions as he goes if you have...
Yes, so feel free. More interactive sessions is a bit much better. I hope I have only limited slides, so we have more discussion. That's better. This is a work in progress, so it's not finalized version of a finalized product. So I'm going to learn more from you than what I'm going to present. So I'm just hoping that you'll ask me more questions. So this is a joint venture between Albert Einstein College of Medicine and Mount Sinai Adolescent Health Center. So it's a NIH project. It's a grant. So just to give a background, that's a single slide. We know most of you work in this area now. It's more than over 6 million children each year are being referred to Child Protective Services for various type of maltreatment. Some of the studies like whatever being examining these abuse and neglect, either they present abuse or neglect separately or they target sexual abuse, they take independent one. None of the studies present a whole holistic picture. Okay, so to give a background, basically, looking at the adolescents, this project came out of a cohort study which is ongoing on HPV infection. So in adolescents, I will give you a background in the following slides, but we wanted to learn more about the history of child maltreatment in every section of it. So that's the main idea behind this initiation of this project. And we also wanted to do examine the relationship between the childhood abuse and maltreatment, neglect, basically towards high-risk psychosocial behaviors and high-risk behaviors. So to start with, the main aim of this talk, the study, basically what I'm going to present is to try to present the association, what we found between the reporting of the child maltreatment and there are many things we are looking at currently, but I'm going to highlight 5 outcomes, which are psychosocial behaviors and high-risk behaviors. To mention some, so the highlighted ones, those are the ones I'm going to present some results. So psychosocial factors, antisocial behavior or delinquency that we are looking at, and depression, which we are measuring as well. Then peer deviance or delinquency, those are the ones. The high-risk behaviors, the ones which I'm going to present results are unprotected sex under the influence of drugs or alcohol. And there is a instrument which we use to measure drug and alcohol use separately. So that is also going to present. In addition to that, other areas like other outcomes which we are trying to write up the paper and finalizing things are related to infections, especially this is a high-risk adolescent population, which whom basically they try to have the main inclusion criteria is they have to have vaginal sex or anal sex, so they have a number of partners, and so we are trying to monitor all these things. Infections, especially sexually transmitted diseases, cervical and anal HPV. And one thing which I missed out here is the teen pregnancy. So different things we are monitoring. To give a background about the study population, this is a cohort. Right now we have around 1,200 adolescent registered part of the study. This is a majority of the adolescent girls come into the cohort are from the inner city, Bronx, Manhattan, Brooklyn, totally New York City, inner city, low income population. Predominant are Hispanics, around 60%, and the 30% that form into like African American and other populations. It's a combination. The data collection is done at the Mount Sinai Adolescent Health Center, and what they do is the Adolescent Health Center uses a unique model where they integrate all sort of medical, dental, sexual, reproductive health, and these services are free to these adolescents who ever visit the clinic. So no questions asked; they can walk in, walk out. So the center per se targets the 10 to 24, and most of them are 80% of them are female, so they go for their services. So. More about the study started with 12 to 19 years of age, and we follow up through 24 years of age. So the inclusion criteria to be part of the study is, as I mentioned, like they have to be engaging in a vaginal or anal intercourse and intend to get Gardasil vaccination. So either they have gotten it and they are getting a booster at the center, or they are naive when they are visiting the center and they are ready to take all the 3 doses. Okay, sometimes some adolescent drop out, they come back. So those are the things. The exclusion major criteria which I thought I'll mention here is women who are pregnant at the time of recruitment or who terminate the pregnancy the last 1 month.
Question?
Yes.
Have ever engaged, women who've ever engaged in intercourse, are you talking, is that question specifically consensual sexual behavior, or would that pick up young women who were raped?
Mostly the cohort consists of consensual, and the gynecological examination, the clinical examination, they do ask question about rape, but that doesn't come under the study thing because we don't have ethical clearance. We have some data collection from the gynecological forms, but not pertaining to this.
So it's based on their self-report?
Yeah. Yes. We do know track because these adolescents, they go to the clinic, so we have some of the data. We have permission from the ethics committee to gather the information, but we are trying to more and more increase the questions, something like what you have asked, so we can go back and get all those clinical data. So right now we are in the process of getting those, especially related to rape and pregnancy. So pregnancy is also sometimes like we have some data on self-reporting, but also there are some data in the clinical data, so we are trying to merge those things. So yeah. Okay. So for the cohort, basically, because it started as a infection cohort, HPV infection cohort, so they were enrolled, they did some standard risk factor and behavioral questionnaire, and the cervical anal data were, and STD infections were self-report as well, but we considered for the analysis, which I'm not going to present here, is lab-based, all confirmed lab-based infection. Then we slowly started thinking of going into behavioral questions, and we started adding those questions related to, so child trauma questionnaire was introduced to those adolescents later, like around 2012. So, and because that's the questionnaire which was used to collect the child maltreatment information. Similarly, peer deviance and depression scale, everything was later, and we followed up every 6 months. These adolescent girls, as per the dosage, they are monitored, and also they followed up every 6 months until the age of 25 they reach. So if they come on 12 years of age, they will be followed up as far as they turn. And so they use the mechanisms like cell phone, text messages, app, Facebook, all possible the social media to recruit them as well as keep them in check. So for this study, so since the child maltreatment questionnaire was not introduced at the early of the cohort, so we couldn't catch up all these, like we lost pretty much around 300 adolescents. Either they were not there, or they have already completed the age of 24 when they enroll by the time we end. So we were able to give this questionnaire to only 882 adolescents, and we were able to secure those information. So I put the childhood trauma questionnaire. I think this has 28 questions. It measures 5 child maltreatment, like physical abuse, emotional abuse, sexual abuse, physical and emotional neglect. In addition, they also have a 3-question forming a scale of denial. So it consists of, so it asks about different questions, and I think it has a good sensitivity and specificity to pick up the child maltreatment scales. Okay. Some of the outcomes which I wanted to mention, which I'm going to do, is was adapted from different studies. The one is the antisocial behavior and delinquency, which is from the Adolescent Health. We kept the score greater than 3 on a 13-point scale as the positive behavior that is positive to delinquency. Then unprotected sex also been adapted from Ad Health survey. The question what we use modified is how often have you been under the influence when you had unprotected sex. So it's a binary question with the response. The other questionnaire which I can think the one is alcohol and substance abuse, which is a 6-question based developed and approved by the American Academy of Pediatrics. I think the CRAFT, I think it stands for car, relax, alone, forget, friends, and trouble. I don't know why they found that one, but each question is related to substance abuse. The car is the one, whether have you ever driven in the car as a passenger while you are drunk or something like that. So, and the scale how we defined as a positive event is greater than, if greater than or equal to 2, a score of 2 would be a positive. So, of course, depression scale is the CAST scale on a 20-item scale, and we consider greater than or equal to 16 score as considered positive. And the final outcome, which I'm going to present as part of them, is the peer deviance delinquency. Here I mentioned, I think it is adapted from Chicago Youth Development Study. I think this scale has been used in Denver Youth Study in a different scale, and it has been used as part of the National Youth Survey. So we used a modified version of 17-item scale to measure the peer delinquency. And for the analysis purpose, this one was difficult for me to make it into binary, so I kept them as severe. Somebody rape and severe using cocaine or anything, they were considered severe, then mild to moderate as one category, and no deviancy as one. So I modeled even the results as ordinal variable instead of a binary. Okay, so I'm going to talk 2 major items in the statistical methods, as most of you familiar with the logistic regression, that's for the multivariable models. All the models are adjusted for age, race, lifetime number of sexual partners. Some of them are adjusted for, the cross-sectional models were adjusted for vaccine status at entry. Why we thought that was very important was most of the adolescents who came to the clinic were already had 1 or 2 doses outside the clinic. So we have to go back into the records to find out what was. So that group was different from somebody who is coming in at the age of 15 or 16 without any, as a naive adolescent, so no dose. So we thought it's good to adjust. That is only done for the cross-sectional. And as I said, like the cross-sectional, the ordinal models were done using the cumulative logit model. On the other hand, since this is a cohort study and we measured the outcomes, all the outcomes, whatever I mentioned, repeatedly every 6 months, and we wanted to make use of all the data. So I fitted a longitudinal model. It's a generalized linear mixed model, considering a random intercept as, I'll give you more why I choose that. And again, the choosing of how the data, if it is a binary outcome variable, I fit a binomial distribution with a logit link and a multinomial distribution with the cumulative. So the reason for modeling with the random intercept is to give each adolescent their own a different risk, a flexibility of starting at a different risk. As somebody who is having 7 sexual partners, both anal and vaginal sex partners, is at a higher risk than somebody who has one vaginal sex partner. Okay, so you cannot assume that a marginal model would assume everybody to be same and everybody starting at the same risk. Instead of giving that, moving away from that, this model allows everybody to start at their own risk, and it's a conditional model, so it gives a flexibility to estimate the association or risk in a different way. You can ask that why I fit only the random, did you check for a random slope if the risk is also changing? I did examine those, but it's not proving up to be a better model, so I had to switch back to the random intercept where the baseline risk is different for each adolescent, but the trend of the risk over the time is same for everybody. The rate of increase is pretty much the same, but the starting risk is different. Okay. Any questions so far? I think the more fun part is the result section. We'll discuss more on that. So here is the basic distribution, the average. Something wrong. Okay, I know what happened. There's a typo, yeah. So the standard deviation was centered, so it's basically, I think that there's the average age, I can say is 18.1. Okay, so it was centered, so it was centered at like 13. So I'm sorry about that. It's a typo, I missed that one. So the average age is like 18.1, but the standard deviation remains the same, 1.3. So that's fine. You can see 60% of them are Hispanic. So because we asked this group as so somebody who is African American, but ask them, are you Hispanic? If they mark themselves to be Hispanic, so that category trumps the African American category. So that's why you see most of them tend to be 60% tend to be Hispanic of ethnicity, and we put the rest of them 35, 40, almost 36% to be African American, and very small proportion to be of the 882 sample, like 4% to be other origin. I think the vaginal sex lifetime partners, I can say one is that's the eligibility criteria, but 3+ it ranged between, I can give you can see the like 3+ 17%, it ranged between 3 to 17 or something like that. So anal sex is the same thing. I kept the distribution because I was going to present the infection data as well, then I removed it. Okay, here is the prevalence of child maltreatment, and the CTQ questionnaire, the child trauma questionnaire, grade the definition of each abuse and neglect in different categories, like mild to moderate, severe, extreme. So that's why I gave up. So basically low, moderate, severe, different colors. So you see the sexual abuse is around 17.5, it's 18%, and physical abuse, self-reporting is 20%, and emotional neglect tend to be the highest among, which is almost, some of them are closer. Some of the literatures, when we compare, the results are pretty much closer to what we see in the adolescent population. So the reporting by the questionnaire not only gave, so it's not, when you say sexual abuse, it's not that children, the adolescent, they report only sexual abuse, they also had multiple abuses. For personal reason, but you may, as some of you are experts in child maltreatment area, for me, distinguishing by sexual abuse by categories, it's physical abuse I can at least understand. You can say minor, moderate, mild, moderate, severe, but sexual abuse, for personally, sexual abuse is a sexual abuse. Either it's mild or moderate, they cannot classify them into. So for the analysis, all the analysis, I considered anybody who had reported sexual abuse to be sexual abuse. Okay, I didn't classify them, but also I grouped them to be, that's the severe form of it. I grouped everybody who had sexual abuse plus other form of abuse, physical, emotional, and other neglects as well into one pie, small pie. And this is the poly-victimization, how many reported neglect only. This neglect only means it involves both emotional as well as physical neglect. Okay, so how many of them had? Similarly, abuse only is both emotional and physical abuse. So I split them, but I grouped them into, to give you an idea, like what is the percentage, how many had multiple abuses, or so neglect and abuse is around 15%. So this gives an idea what is the distribution of poly-victimization, like different varieties of abuse and neglect. Now, moving into to give an idea on the outcomes, what I'm going to present, these are the prevalences reported at entry. This is not a follow-up or anything. At entry, when we measured at the first visit or the first time when we administered, how many reported antisocial. So this is the at entry, study entry. You can say antisocial behavior was 30%. So peer deviancy shows us 86%, but this 86% of prevalence reporting of peer deviancy, only 22% are severe peer deviancy, marked as severe peer deviancy. So I need, and around 40% have reported unprotected sex. One thing I just wanted to mention it as there was also another question we examined, received monetary benefit or other benefit in exchange of sex was also measured. But the percentage was 1.5% in this adolescent, so I didn't put in for this presentation the details. So just wanted to mention here. And around clinically measured, the scale-based depression was around 27%.
Remind me what peer deviance is.
Peer deviance is you ask the like whether any of the friends, the adolescent's friends, have done any delinquent behaviors, like whether lied about age to get alcohol, or ran away from home, or something like they have stolen money less than $100, less than $50, or they hit somebody to have sex, or they have robbed somebody, broken into a home. So these are the questions. And alcohol use, marijuana use, cocaine, they have sold any of those things. So here, so from now on, the association slides which I'm going to present is, I will go back and forth, but the first slide is a cross-sectional at the time of entry, or where the questionnaire were administered. And these models, every model put in the result is not the polyvictimization as a variable, but as like each independent variable. How many of them had a sexual abuse? Yes, ever had sexual abuse or not? Adjusting for other covariates. We didn't put the other type of abuse and neglect on the covariate section because there might be some kind of influence, so we wanted to avoid that. So the models, all the models are adjusted, cross-sectional models are adjusted for age, race, ethnicity, and vaccine status, and the number of sex partners, because that is one of, yes?
So something that you might want to look at just because it validates your findings, but comes out of this kind of thing left field, and that's Teicher's work on functional MRI and limited irritability. And he did one study in particular that looked at combinations of physical abuse, sexual abuse, emotional abuse, witnessing domestic violence. And it's interesting that some of your results parallel in terms of severity of symptoms. So you've got a physiological indicator that I think correlates well with your epidemiologic findings.
So whose work did you mention?
Mark Teicher, T-E-I-C-H-E-R, is it clean?
I'll write it down.
Okay, thank you.
T-I-E.
T-E-I-E-C-H-E-R.
Mark Teicher. He's an MD, PhD.
Can I ask one?
Yes, sure.
Clarification? When you asked about sexual abuse
Yes.
history as it's reported, did you distinguish between intrafamilial and extrafamilial sexual abuse, or is sexual abuse by anybody looked at the same way?
I think we followed the questions exactly as in the child trauma. We didn't ask about whether within the family or the outside. We didn't ask that. So because these adolescents, like first we wanted to try, we started as a pilot study because we were not sure, like already they were going through rough path. So we were not sure whether they will take up this kind of reporting. So when we started it with 150 as a smaller sample, like so we didn't go further in depth. So we were proposing to, in fact we are in the process of writing a newer grant, putting in a grant to measure this one as well as other factors like cortisol and other things we are measuring, how they are clinical parameters. So thank you for telling the reference. We'll go through this, and maybe an MRI would be good too. Yeah. Yes?
Maybe since we've interrupted you already, before we get too far away from the slide where you were talking about the different kinds of prevalence of different kinds of behaviors.
Mm-hmm.
The one that stood out was peer deviance.
Yes.
That Carol was talking about. And so on one hand, we're talking about, for example, physiological things. Depressive symptoms certainly have a behavioral emotional, but there's also a physiological way that we test for depression. I mean, in terms of certain blood chemistry levels and things like that. But it interested me because I think for those of us that have been around the tradition of the Kemp Center, relationships are at the heart of much of what goes wrong for children who've been abused or neglected. And so it interests me that one place where they're twice as likely to be doing things that are not helpful is to be in a network of peers who are not going to be healthy for them. But on the other hand, it tells us something about what goes wrong for children who grow up in less than good enough care. And it really, to me, that represents a finding that suggests how powerful it is when children don't learn how to dance emotionally well.
That's true. And in fact, since you're saying we'll see the results, it's peer deviancy is more strongly associated with the emotional those who reported with the emotional aspect of abuse or neglect, we'll see in the next couple of slides, down the slides, than somebody who had a physical or a physical neglect, abuse or neglect. What you're saying is exactly right. It's fascinating, like in a sense, like, means yes, some of these results are already published. When we are trying to look at it in a different perspective, yes, this stands out, and they're so strong. And especially when I was cross-sectional, of course, when we started the analysis and when I was analyzing the data, cross-sectional was interesting, but when I started looking at why are these people like repeatedly doing? So the antisocial behavior, when we administer every 6 months, it doesn't ask lifetime, it asks like, have you done in the last 6 months? Some of these questions are like, have you involved in the past 3 months? So it's very close enough, and we see how many times they hit the numbers. So absolutely, what you're saying is very, very, very true. So, and you can see this, the depressive symptoms is very strong with the emotional. Again, what you are saying is it's related to, it's physiologic is one, and there's a trend. High-risk behaviors goes with, in fact, in the summary, I put it as like, high-risk behaviors, they are more tend towards abuse, but any physiological, depressive or peer deviancy, like where they're looking for a support or something, it's more going towards the emotional aspect of it. Okay, so here, this is a cross-sectional aspect of it, and we see at the entry, we see the physical abuse is strongly associated with the antisocial behavior, but the rest of them are, that is the only of the outcomes, whatever I have studied or examined for this, the sub-cohort analysis, is that's the lowest, smaller magnitude what I observed here. These are all marginal models. This is, I need to spend a little bit time. So in a longitudinal analysis or any cohort analysis, the interest is, of course, when you are comparing treatment groups or any abuse groups in this scenario, you are interested between the group comparison at a certain time point down the lane, either 1 year down, 2 years down, 3 year down. So what I have presented here is what happened if they are in the cohort over the 3 years on an average. Okay, so if they stayed up 3 years down the age, like this is the timeline, time as a model, in the model was the age. So if they start at 18 years, if they are in the cohort, and what happens like over the next 21 years, what will be the risk of they behaving in an antisocial behavior or they having a symptom. But in addition to the between group comparison, always if sometimes there is, you are also interested in within groups. Somebody who is like somebody who are abused at the start, who have a history of abuse, when they are in the start of the cohort, do they increase or decrease over time in their depression? Like you're trying to look at it. So one thing is, because it was becoming too much slides, so I am currently here presenting only the between group comparison at 3 years. What happens 3 years of age? What is the comparison between physical abuse or any abuse or neglect versus those who did not get any abuse or neglect? So that is the results I'm presenting. So, and also one tricky part with the conditional model, what I mentioned about the random intercept model, given, so you have to make an assumption that this result, the odds ratio when you are interpreting, the risk of doing an antisocial behavior is your comparison is this between individuals who are having the same baseline. That's a strong assumption because there is no way to get around with it, but that's a stronger assumption you need to make. For example, somebody who are having a 20% risk, 20% risk in the physical abuse group at the baseline, you are comparing the 20% risk who has the 20% risk in the non-physical abuse group at the baseline. Then what happens over the period of time? So that's the conditioning upon, it's a conditional odds ratio rather than like a marginal. The previous slide is something like you are saying on an average what happens. So given that they have the same risk, what will be, so same baseline risk, what will be the risk? So it can be like 50% risk somebody has, so you're comparing against a 50% in the other one. So it's a strong assumption. Not everybody is going to have that one. It's a strong assumption. So I just need to make a caution. So you can look at here the depressive symptoms. You can see the at 3 years when you are comparing between sexual abuse, those who reported sexual abuse, it was almost 4 times the risk. Yes, go ahead.
So just a clarifying question. So was the abuse and neglect measured at baseline, and then depression and antisocial behaviors were measured longitudinally over 3 years, or was the child trauma questionnaire administered at each respective period too? Like, are the abuse and neglects all from the baseline measurement, and depression and antisocial behavior the outcomes that are being measured over time? Or?
Yeah, the outcomes are measured every 6 months, like follow-up times. We do administer we do for consistency's sake. If some adolescent who said no or don't want to fill up the first time, they might fill up the next time. So we do give them, and also we do for quality assurance, like we want to say first time they say everything no, then later they change. These are like the child trauma questionnaire is being administered every time. But the thing is, like, we wanted to see that if we are not monitoring it, because it's asking a question lifetime. There may be some adolescent kids who are undergoing abuse even now, and we are no way, because of many reasons, no way we can ask that, or reporting legal reasons. We are not doing that.
So the exposure of abuse and neglect is any time up until the measurement
is made. And also, you're right, and also we do administer them the following visit, so that if they change results, we wanted to see, especially. But the outcomes are measured every 6 months, or whenever within the range of 6 months. They are supposed to come 6 months. Sometimes they come at 4 months. Sometimes they don't show up until 8 months.
So
it depends.
These that you're showing us now are 3 years out from baseline.
Yeah, it's modeled at 3 years, but everybody on an average, I think we have a follow-up like 2007 now, so 9 years in. So I'm just showing if whatever on an average, like 3 years of age, not the follow-up visit, 3 years of age. However, it can be 18 years starting going until 21. What happens comparison?
Right.
That's the time. So looking at it, you can see the higher risk is the emotional abuse and the sexual abuse with the depressive, and also the higher risk is emotional neglect. But you can see there is a stronger, like, positive trend towards antisocial behavior, but none of them are statistically significant. None of the abuses or neglect didn't show. So I'm exploring further into if I can understand the mechanism, if I can tease out other hurdles why we are not showing. But the association, the magnitude per se is around 2. You can say 1.9 to, it ranges between 1.9 to 2.4, but none of them are significant. Yes?
So are these adjusted for age at baseline, or are they adjusted for age at 3 years?
Basically, age in these models are the time variable, so they are part of the model. Age is a time varying thing, time dependent, and they are the linear variable which goes in. So there is each group is, so you are looking at increment over the age, whatever each adolescent is. So it's adjustment where I put here is like as it's part of it, since it's a longitudinal model. Yes.
So have you looked at the interaction between that and antisocial behavior in this model?
Can you repeat that question?
Have you looked at the interaction between age and antisocial behavior in the model?
Because you'd expect older kids to have that.
Well, I would say older kids have fewer, but I don't know.
So in these model, basically what we are, okay, let me try to answer it. Let me know if I answered your question. Since the model has, there is an interaction between the abuse and age, because somebody who is 18 years old had longer time, and also the lean-in time bias, kind of like they are mature than the younger kids, and they are more likely to come out and say report an abuse or neglect than somebody who is 13 years old. Or in another way, they can also work out in another way. Like, so we are modeling. So there was an interaction put up for the time and age. That's how they increment the odds ratios over time for each group by what is the age. What you are asking is if we split the age group and see what happens, like as a sub cohort. I worked on it, but I don't have a result here. So because that is like segregating age cohort. You are looking at a cohort effect, age cohort effect, like what happens, like somebody from 13 to 15 years, then 15 to 18 or 18 and above, what happens. So I have those results, but I don't have it as a slide here. Yes. Thank you for asking. Yeah. And this model do not have a vaccine status because we feel that everybody who comes into the cohort start getting vaccination. So it's no point. So, and it's not, we did start putting in the model when I started, but I had to remove it because logically it didn't make any sense, but also it was not informative. So if you look at, so here most of them are the emotional aspect of emotional abuse and the physical abuse. For those who they had a higher magnitude of association. The odds was like threefold for the abuse, physical, and the abuse category is much more higher. On the other hand, the high risk behavior of unprotected sex. Okay, so what we are looking at is like 1.7 times the risk only for the abuse. Like those who are abused are more tend to have a unprotected sex favoring towards it than somebody who are neglected or sexual abuse. My understanding, my logic is they are abused and they may be traumatized and they're maybe staying away from it. That's the logic. But those who are abused are more likely to involve more and more activity of unprotected high-risk behavior, sex, under the influence. Especially, it's also under the influence of any type of drug, marijuana, pills, and alcohol. So that's one thing. Any questions? Yes.
But you don't know whether that unprotected sex is coercive sex, right?
No. We have only one question on asking whether the question was like, have you ever so involved in having under the influence, whether you have had, how often, and this is asked every 6 months. This is the longitudinal, again, stronger thing is with abuse, but now the unprotected sex is only involved with emotional abuse. You saw that the previous association was with both physical and emotional. When we started looking at longitudinally what type of relationship, whether they are going, those who reported they have an emotional abuse more tend to have going, so it's 2 times the risk. So, and that was the statistical. So all these models I wanted to mention here is not only analyzed this way, we are also looking at mediation models, mediation and moderation models. So this is one angle we are looking at it, and the presentation I'm doing, but soon we'll have the other results. So that's where we are going. Peer deviancy. So the model, how I did, I wanted to mention here is there were 3 categories. I don't want to make them into binary because the magnitude of severe is much higher than that in the mild and moderate part, and adding them will lose information and also power. So how I have modeled is arranged in the probability of somebody. So there are, by modeling a cumulative logic model with 2 categories, what it is modeling is probability of severe versus mild or moderate and no deviancy. The second cut point models probability of severe plus mild moderate versus the no deviancy. So you have two cut points. So after adjusting those cut points, what is the average odds ratio between those two groups? So the peer deviancy here, most of them are, as a cross-sectional analysis, we looked at is the abuse and the neglect. Okay. On the other hand, my interest was more looking at as it changes, does it change whether they have reported peer deviancy every 6 months? Here, the physical neglect doesn't play into role. The emotional neglect and the two higher thing, the magnitude is 7 times more or 6 times more if they are abused to go towards peer deviancy. This is an average odds towards both the cut points, the starting cut points, modeling probability of severe versus moderate plus no deviancy and probability of after adjusting for all other things over that period. So this results at 3 years of age. Okay, so the estimate could be if you are modeling. So some of them, why I modeled at 3 years and present the result here is some of them are still who entered into 2013. They are still within the 3 years age group. So I don't want to go extrapolated. Even generalized linear mixed model has an issue extrapolating. So I have to stick with 3 years. So down the lane, the idea is to see what happens, whether their behaviors are changing. We wanted to examine further into more than 3 years and 5 years of age.
So what this is saying, let's make sure I'm understanding you. So what this is saying is that kids who have been who report having been physically abused before they came into any time up to now, are 7 times more likely to to know peers who are deviant.
If they have if the baseline risk, assuming that their baseline risk between the comparison group and the two comparison group, the adolescent whom you are comparing, exactly having the same baseline risk of peer deviancy.
Okay, so adjusting for baseline.
Because that is like you are assuming that, because you need to assume that the baseline risk is exactly the same, because you cannot remove that from that. So to summarize, basically to summarize, we see a high prevalence of childhood abuse and neglect, but this is in tandem with whatever the other reports available outside in the literature. We are also trying to see we can incorporate some kind of additional questions to probe. So that's where we are in fact trying to get more questions in, asking, and also we are trying to see if we can get some information from the clinical records, or so we can go in. So my collaborators are working on that. So that's one thing. To summarize the cross-sectional analysis, we discussed the emotional abuse and neglect go with the physiological aspects of it, with the depression. The abuse especially is strongly associated cross-sectionally with high-risk behaviors. Deviant peers are most like association with them were positively associated with with reported abuse. Whenever they reported it, they had abuse, irrespective of what type of abuse, sexual abuse, emotional abuse, they were cross-sectionally. That's the result, but the longitudinal assessment showed a little bit different picture. The antisocial behaviors tend to be, there is a higher magnitude, but none of them are statistically significant. That's one thing. And they had adolescents reporting sexual emotional abuse and neglect had a 3-fold risk. So basically, to summarize this one, what we observed, and the conclusion is so these adolescents who come into, they need support. They have a child. Of course, this is a known phenomenon. Like we know that all these kids need attention, but So the next step towards what we are trying to say, how we can measure them in better way and provide help to them. So that's what we are working on. So we are also addressing other issues like trying to measure their anxiety through physiological parameters. So we are trying to work on some of these and extending this in different aspect, and counseling. We are thinking they do get counseling. We are trying to provide more additional help as more practical scenario what we are looking at for those adolescents. Yes.
I might have missed something here, but so was the HPV cohort just a convenient cohort to kind of ask these other questions, or how does HPV play in, and like why were you adjusting for vaccine stuff? Like I'm just confused about how.
So the cross-sectional model, we use the vaccine status as an adjustment factor, because the cohort didn't start with all the adolescents who did not get any vaccine. The cohort started with some getting all 3 doses, some had partial dose, some had one dose. The partial dose can be 1 or 2 doses, and some with naive, like they. So
did you think that was associated with abuse and neglect, or with?
No, we wanted to, because the status, if aware of where to get, what to get, and their compliance to, that's a behavioral aspect. We did healthcare, health-seeking behavior. So we wanted to adjust the health-seeking behavior, like how many of them had completed or something. We just published a paper recently in Journal of Pediatrics on knowledge and this thing on HPV receiving the dose. So we did do that. So that's the reason we said as a behavioral, like whether how many doses they have completed or how we know getting into the, so we adjusted for that, but not for the longitudinal, because that doesn't make any sense. Or like somebody who had entered with 2 doses within 6 months, they have all will have 3.
See, and I had the opposite thought. It's a minor point, but leaving that out, that adjustment out on the longer one would be important to me, because if I knew someone was engaged with this study but didn't have their 3 doses within that time range, I would think they were not as compliant with care. And that would be an important clinical risk factor for me.
That's a good point. Yeah, the paper which I mentioned we just published, we did evaluate that one. We didn't find any difference, because even the dosage, like we showed in the paper, like even a 2 dosage is as good as 3 full doses. So we didn't.
Told them to get 3, but then they didn't.
They didn't.
Regardless of whether they really needed it.
And also one issue we had, why another reason why I didn't add them in the longitudinal model is some of them who came with 2, we really did not know when they got. Most of them we could go back to the registry to get when they got the dose, and between the 2nd and 3rd dose when they got in the clinic, we couldn't get some of them traced out, like how long ago they got the first dose, how long ago. So it's very difficult. So I don't know, it contaminates, like, so to avoid those confusions, so, and it was not significant either, so when I was fitting the model, but it's a good point.
We know, as a separate point, Heather Towsett here has done work with foster youth who are high risk, and I think what would be interesting as you try to suss out, why you've noted some of these things, was she found in her cohort that kids who were exposed to community violence actually were more strongly impacted with some of these more personal risk factors that we might assume. So if you look at these later down the road, I think
we are trying to monitor them. So that was one of the things which we started doing. We are asking about family violence within the family. We do have information. We also the surrounding neighborhood, because these are poor neighborhood, and some of them are almost like
your
live in the.
child trauma questionnaire gets to some of the domestic violence questions.
No, the child trauma questionnaire is just these 5 aspects of the child abuse and neglect.
You didn't use the whole measure?
We did use, but it doesn't cover the outside.
I thought it asked if you'd seen your parent get hurt or something like that.
No, no, it's not there. So we are trying to monitor, because we are more and more what we are trying to. So that's why we went into adding on the counseling because yes, we observed this as a cross-sectional history, but there are a lot of kids who are hurt by pure violence, somebody died next to friends or somebody, that causes trauma as well. So we are putting in. So.
And conversely, if you had to add pro-social measures, would be really interesting too. Like, had they gotten through high school and why? Did they have a mentor? You know, you seem to focus on more of the risk factors instead of the resiliency factors.
We do measure that.
Okay.
Yeah, we do measure social support, their socioeconomic status, whether they are including whether they are living with an adult, who are they living with. We measure whether they are on food stamps, they have enough food, whether so we do measure all those things. But in this presentation, I'm just kept it simple.
Sure.
Yeah. So we do have an extensive their social support. Where do they go? We have extensive questions. We are building one by one over as a block. So as we progress, we did more. We first concentrated more on the infection because an infection cohort and it's infection in terms of post-vaccination, like whether they are getting. So the focus was on. Now we are turning more into behavioral. So that's where the focus now is slowly changing. And I think this is the last slide. If you have more questions or suggestions, these are some of my collaborators. So this is, as I said, is a collaboration between Mount Sinai Hospital Adolescent Health Center and the Adolescent College of Medicine. Some of it, and this is a NIH grant, so funded things.
Great. Any final questions? We run out of time? Great. Well, thank you, Shankar.